it says pulmonary because I want to integrate Sjogren's with pulmonary. So a 65-year-old woman with a 20-year history of Sjogren's syndrome is seen for an abnormal CT, which is down here. And when I'm looking at this CT, it looks like she has a bunch of cysts over here. She has mild, non-progressive dyspnea on exertion. No fevers, no weight loss, no cough. On exam, vitals are normal. Lung examinations, clear lung fields, and heart sounds are normal. There's no digital clubbing. Labs, hemoglobin solid. The following serologies are there. The A&E has a big titer. Positive double-stranded DNA, a positive SSA and SSB, which is anti-Rho and anti-Law respectively. PFTs have a normal total lung capacity at 98%. Vital capacity is normal at 88%. FEV1 is normal at 90%. The ratio is normal at 76. DLCO is normal at 85. She does a 6-minute walk. She's 65. Give her a break, But she walks 1,000 feet with a stat of 96% at rest, 94 with exercise. That's about right for a 6-minute walk in a 65-year-old. So she's great. And this was a CT scan that shows just a bunch of cysts over here, and she does have a history of Sjogren's. So what is the next best course in this patient, everyone? Should we give her a surgical lung biopsy? I think that's a little aggressive in someone who is having non-progressive dyspnea, just doing well. PFTs are doing good, walking 1,000 feet. I just don't want to surgical lung biopsy. Should we immunosuppress her in this asymptomatic patient? I don't think I would do that. Would I perform serial CT imaging? That's really tempting. Maybe serial PFT, serial CT imaging. I think both of those are really tempting. Would I do a bronch with a transbronchial biopsy? I think if I was ready to start immunosuppression, I felt she needed to be immunosuppressed, I think I'd be a little more aggressive about that. But in someone that you're painting a picture that, hey, she really is asymptomatic and doing well with good PFTs, I think most of us will say we're going to do what? Nothing. So the right answer is C. I think we'll just do some serial CT imaging, maybe consider doing a repeat spirometry, see if she's changing herself, getting worsening with symptoms, that's different. But 20% of patients with Sjogren's have pulmonary disease, and most of these patients are going to be asymptomatic with just having findings on chest imaging. So Sjogren's can definitely give you an interstitial lung disease, why I kind of put this here. And, when we talk about interstitial lung diseases, the ones I listed here are called idiopathic interstitial pneumonitis, meaning that, there are people who could have all these crazy lung disease, but they're idiopathic. But because she has Sjogren's, we can't use the word idiopathic. I really want to pound home the point that when you have a rheumatological disease, when you have a connective tissue disease, you could have any of these findings that we see in these idiopathic disorders, but they're not idiopathic. So Sjogren's can give you any of this non-specific interstitial pneumonia, usual interstitial pneumonia, organizing pneumonia. If it's idiopathic, we call it COP, cryptogenic organizing pneumonia, but because this patient has Sjogren's, it's not really cryptogenic, it's just an organizing pneumonia. So what are we looking at here? With all these little cysts, this is not something I need you to dwell on, but this finding of having a bunch of cysts in the setting of someone with Sjogren's is what we refer to as follicular bronchiolitis, some diffuse random cysts of various sizes. And this is on a continuum with something that we call LIP, which is written up here, lymphocytic interstitial pneumonia. The difference is that when you have this LIP, you may have a bunch of cysts, but you'll see a lot of ground glass. And these patients are pretty symptomatic at that time. And I think I would change my answers on my workup if I feel I needed to treat this patient with steroids or under immunosuppression, but just not in this case. So when we do consider using therapy immunosuppression, of course, would probably use steroids first. And I would consider using medications like Celsep, mycophenolate, or azathioprine if I want to actually help taper off the steroids or they're not doing well on the steroids. And if they're refractory to it, a lot of these rheum diseases are antibody producing. So when we talk about the lungs, for tough cases, we may use a lot of rituximab because it's going to work on those B cells, inhibit those antibodies, and that would be something I consider. If this patient is developing pulmonary fibrosis, which there's no indication there's pulmonary fibrosis, and you're going to ask me, how do you know? If I see honeycombing, which is kind of like these stacked cysts, which this patient didn't have, they were starting to develop fibrosis. This is not idiopathic pulmonary fibrosis because this patient has what? Sjogren's. If they didn't have Sjogren's, you could call it idiopathic, but this is going to be pulmonary fibrosis. There's a medication called nintedanib, which I would know for your board exams. Nintedanib goes by the brand name Ofev. It got the FDA approval for any type of interstitial lung disease that is just progressing to fibrosis, a kind of progressive phenotype. And this medication is not going to be the anti-inflammatories that we're using up here, such as steroids or mycophenolate or azathioprine. Nintedanib is an antifibrotic, and its claim to fame is that it really slows down the progression of the decline of the forced vital capacity. So the vital capacity is going to be going down pretty quick in these patients. This medication, nintedanib, that got the approval for all these ILDs with this progressive phenotype, it slows down that decline in the FVC. Of course, this drug has many side effects, such as diarrhea and more diarrhea. And I put this picture here because I mentioned that this diffuse, this follicular bronchiolitis over here is a continuum with something called LIP. And now you could really see just a bunch of cysts, but everything else looks good. But look at this picture here, everyone. Bunch of cysts, but look how that ground glass. So this is kind of LIP here, and this patient does look like they would be more symptomatic over there. So what did I want to talk about here, everyone, is Sjogren's. That's what you're going to have on your boards. It's a chronic inflammatory disorder, getting to diminished lacrimal, which is always going to be the eyes, and salivary gland function. Sjogren has two forms, everyone. It has a primary form that's not associated with other diseases. It's the primary form I always worry about. Are they going to be getting lymphoma, such as non-Hodgkin lymphoma? Are they going to get things like multoma? Or Sjogren's could be secondary to other diseases. And what's a very common rheumatic disease associated with it is rheumatoid arthritis, When we talk about, whether it be primary or secondary Sjogren's, it could definitely lead to a decreased exocrine gland function, and you get that Sicca complex, which is the dry eyes. They call that keratoconjunctivitis Sicca. And Sicca, by the way, is just a Latin word for dryness, just in case you're wondering, or a dry mouth, what they call xerostomia. Now, when we talk about the manifestations of whether it's a primary or secondary Sjogren's, you could have what they call glandular features or extraglandular. And these extraglandular is how I always say Sjogren's affects every single organ in the body. So you're going to ask me, well, what organs are you talking about? So let's get to those. But I did mention for the glandular features, there's that Sicca complex, just to say it one more time. If you have the dry mouth, of course, xerostomia, you worry about dental caries. It happens up to 65% of patients. Oral candidiasis happens in quite a bit of patients. Dry eyes, of course, can be very irritating. Salivary gland enlargement, one of the classic ones we think about is parotid gland enlargements with Sjogren's, which is why Sjogren's can mimic things like sarcoid. It can mimic things like an alcoholic-induced cirrhosis. Alcoholic-induced cirrhosis gives you parotid gland enlargement also. And of course, you can have dry skin. So some of the glandular manifestations, you can see the dry tongue, why you think about the trips to the dentist. Parotid gland enlargement can be pretty obvious in some cases, or sometimes when you evaluate patients that have the big thick neck, it may be subtle. You may not notice parotid gland enlargement as much. When we talk about, extraglandular, I want to mention the skin. Things that you could think about could be cutaneous vasculitis that you see here on the bottom right. They could get Raynaud's. Raynaud's is not only seen in scleroderma, though we always think of it that way. It could be seen idiopathically. It could be seen with SLE. It could be seen with Sjogren's. You could get annular erythema that you can see on the bottom left. You could get erythema nodosum. It's not just only seen in sarcoid patients or inflammatory bowel disease. And of course, livedo reticularis, we know that it's very nonspecific. And of course, I think this quite often in my medical ICU in people with shock. But here are some of the extraglandular features. We mentioned today that people with Sjogren's can get interstitial lung disease. The one I showed you once again is that, follicular bronchiolitis spectrum with something called lymphocytic interstitial pneumonitis. Sjogren's can affect the GI tract. You can get dysphagia. It can cause pancreatitis, like an autoimmune pancreatitis. I know autoimmune pancreatitis has been associated with IgG4 disease. You can get peripheral nervous system, multineuritis multiplex. Always worry about non-Hodgkin's lymphoma, especially if you have a big lymph node in there. Have a very low threshold to do a core needle biopsy. If it's negative, maybe consider doing an excisional biopsy. It's an autoimmune disease, so it's associated with other autoimmune diseases, such as in the liver, primary biliary cirrhosis, antimitochondrial antibodies. For nephrology, it's associated with type 1 RTA. Type 1 RTA always affects the distal convoluted tubules. And of course, the heart can be associated with pericarditis, and joints, it can give you a symmetrical arthritis. It can give you a symmetrical arthritis also. And I put this CT here if anyone was wondering what honeycombing looks like. This is going to be honeycombing, and definitely people with Sjogren's can go on to develop pulmonary fibrosis with this honeycombing. This is when I would consider that antifibrotic nintedanib for a patient. Diagnosis, everyone. Of course, what do you suspect? If in the olden days, if you had an ophthalmologist right next to you, you could do what's called a Schirmer's test, looking for dryness of the eyes. More commonly, we think about during serological testing. Remember, ANA is not only seen in people with lupus. There are definitely other diseases such as scleroderma and Sjogren's can have a positive ANA. And you think of more specific antibodies like anti-Rho, otherwise known as SSA, or anti-LA, known as SSB. The gold standard, most accurate, would be a salivary gland biopsy. Usually they do a minor salivary gland lip biopsy, which is commonly performed in ENT. And, if I was going to treat someone for extraglandular Sjogren's, of course, I would think about steroids, and I definitely would consider doing a biopsy before therapy. So let's talk about this 45-year-old woman with a 3-year history of systemic sclerosis. Presents with to the clinic reporting increased dyspnea on exertion, dry cough, physical exam within normal limits. We're really referring to the vitals. She's saturating 96% on room air. She has perioral skin tightening. Lung exam reveals crackles at both bases. Cardiovascular exam has normal heart sounds. Extremities is notable for skin thickening, extending proximal to her PIP joints, but there is no clubbing or edema. Labs, she's positive for anti-topoisomerase, otherwise known as SCL70 antibody. PFTs, the TLC is less than 80 at 68%, restrictive. FBC is low at 73%. FEV1 is relatively normal at 82%. The ratio is normal at 84%. DLCO is reduced at 62%. The TLC, FBC, and DLCO have all decreased, though, since previous sets of PFTs only 6 months ago. They do a high-res CT, and when I'm looking at this patient is having findings of fibrosis that are occurring in the lung. I could see some traction bronchiectasis over here, some subpleural reticulization, meaning that more like the spider web, the lines right above the pleura. So what medical therapy has demonstrated efficacy with the least adverse effect? So we have a scleroderma patient with pulmonary fibrosis. Which medication should we think about in these cases? Well, let's do this together. Cyclophosphamide has been used in scleroderma patients with pulmonary fibrosis, but definitely has side effects. Mycophenolate actually has data to be used in scleroderma patients with pulmonary fibrosis, maybe not so much side effects. And we also have another, we have the biologic rituximab that works on B cells. And of course, it does have side effects. It's not one of the more front things that we use in these patients. It doesn't have as much data, and it is a biologic. And pirfenidone is not FDA approved for people who have scleroderma, so that would be the wrong answer. It would be a little tricky if this was someone where they said nintedanib, which was OFIF from another place that did get approved for scleroderma, but not pirfenidone. So which one would I pick here? With seems like there's some active inflammation going on here. There's still some ground glass over here. That I would probably pick mycophenolate. So that is the right answer over here. And, there are a number of rigorous trials, talking about interstitial lung disease in scleroderma patients. Here's another picture of someone with honeycombing. And of course, these trials include comparing cyclophosphamide to placebo, cyclophosphamide versus mycophenolate, and even using the tinidib, which is the antifibrotic versus placebo. And just to summarize this, because I know I want to go on to endocrinology, that mycophenolate, I just put the word preferred. This has been studied in patients who are symptomatic scleroderma patients with pulmonary fibrosis, declining PFT, such as this. This medication is, you start off probably in around 1.5 grams and slowly titrate up to 3 grams daily, would be the preferred agent. Cyclophosphamide was used quite a bit in the past, but because of side effects that we don't use cyclophosphamide up front as we did in the olden days. And this is not a mistake, everyone. Tocilizumab, which is going to be the IL-6 inhibitor, actually got FDA approval for patients with scleroderma who have pulmonary fibrosis, who have the interstitial lung disease. And this is something to consider, maybe in someone who's going to be failing cyclophosphamide, mycophenolate, you could think about this medication. So for maintenance therapy, of course, it's hard to say how long you keep patients on these medications. We definitely know for sure mycophenolate can be continued for at least 2 years, and we'll reevaluate the risk and benefits of staying on the medication. Cyclophosphamide, you can start off with an IV, then go oral. Of course, a lot of side effects there. And for refractory disease, I did mention that this is where you could consider using things like rituximab. And this is not an error right here. There is some data about using hematopoietic stem cell transplant for people who have very bad fibrosis, and they're a scleroderma patient with progressive fibrosis. But this is, going to be last line. So the right answer here is CellCept. And let me talk about scleroderma as whole to really have you guys prepared for the boards. So I really want you to focus on the top right over here. So when we talk about scleroderma, that I put them in 2 broad categories. I put them in systemic sclerosis, systemic scleroderma, or localized. Now bear with me here. If you have localized scleroderma, it really implies there's only scleroderma on the skin. You don't have involvement of the internal organs. So really, when we talk about board exams for the internal medicine boards, they're really focusing on systemic scleroderma, not really localized. Localized only means the skin and only the skin. One of the skin lesions you could see in patients with localized scleroderma is called morphea, and sometimes you could have linear scleroderma. But what are the ones that we classically think about for your boards is called systemic sclerosis, systemic scleroderma, which is divided into limited. Many of you folks call that the crest syndrome. And of course, there's diffuse. Now, one thing I just can't say enough, and probably my take-home message for everyone here, is that, both limited and diffuse scleroderma can affect every single organ in the body. Limited doesn't mean you're limited to certain organs. Diffuse doesn't mean every organ. Limited and diffuse really refer to the scleroderma skin score, which is not tested on the IM boards, stuff rheumatologists do. But as the name implies, limited skin involvement, limited. Diffuse is diffuse. Of course, the organs more affected than limited are the crest syndrome. And in diffuse, they tend to have more cardiac and lung and kidney disorders. So when I think about systemic sclerosis, what are going to be some subtypes under that? There's diffuse scleroderma, limited. There's mixed connective tissue disorders. Remember, that's sometimes called the overlap syndrome. The antibody associated with that is anti-RNP. And of course, what would rheumatology be without another category called syn scleroderma, which means, yes, you could have scleroderma without the skin findings. Go figure. So here's a picture of morphea when you have that localized scleroderma just to the skin. This is kind of a linear scleroderma over here, just localized. Limited scleroderma, please know the crest syndrome. It's a great acronym to use right there, because you're getting involvement of sclerodactyly, of course, because you're going to have Raynaud's and all these things. It's good to evaluate the capillary nail fold bed. Usually you want to see it in the top picture nice, and you can really clearly see demarcated capillaries. But of course, when we talk about, people who unfortunately do have limited scleroderma, you could see distortion of the capillary fold and nail fold bed. Antibodies I think about for limited ANA followed by an anti-centromere. Diffuse, more extensive skin score associated with an anti-topoisomerase, otherwise known as SCL70 antibody. And as I mentioned before, greater risk for renal crisis, lung disease, and of course, the two things in the lung I worry about the most with scleroderma is interstitial lung disease and pulmonary arterial hypertension. And of course, they also can get cardiac disease. In the red box, I wish there was a drug that treats the skin involvement, just wonderfully, but there isn't. And it's really disfiguring, and it's really, these patients can't even move when they have bad skin involvement. They've tried methotrexate. Sometimes they use mycophenolate in these patients to help out with the skin, but it's not a magic treatment, and a lot of patients don't respond. And of course, when we talk about prognosis, most patients, are going to have poor outcomes the minute they have lung involvement, whether it be pulmonary fibrosis or pulmonary arterial hypertension. And other risk factors for increased mortality, more skin involvement, once again, heart and lung involvement is going to be there. And of course, if they get that scleroderma, renal crisis, and renal disease, that's going to be poor prognosis there.